All right, let's do a little HMSB training. Today's topic is hemorrhage or bleeding control and the management of any resulting shock. Remember, as with all things medical, remember to follow the universal precautions and wear all applicable personal protective equipment or PPE. There are three main types of bleeding. The first is capillary bleeding, and it's best described as an oozing type of blood loss that is not acutely life-threatening. So we're not going to address it in this training. The second type of bleeding is venous in nature and can produce large volumes of blood loss. The good news, if there is good news about bleeding, is that this type of bleeding is under a lower pressure and is easier to control with techniques such as direct pressure and elevation of the body part that is bleeding. The third category of bleeding is where we make our money as corpsmen, and that is arterial bleeding. Arterial blood flow is known as a high pressure system, and any arterial bleeding is much more difficult to control and typically leads to much higher volumes of blood loss. Every corpsman knows that blood is used by the body to ensure that proper cellular metabolism is occurring. It does this by bringing oxygen and other required elements to the cells and then removing the waste products to be excreted by the body. But blood also plays a key role in maintaining the body's temperature. Blood loss is a common cause of hypothermia in trauma patients. In 2006, a study by the Army's 31st Casualty Support Hospital in Iraq determined that 18% of the patients that arrived to their facility were hyperthermic. This is significant as hypothermia has a direct impact on the body's decreased ability to form clots, and it's also related to increased rates of infection. The 2006 study demonstrated a correlation of hypothermia to increased mortality and morbidity rates among patients that have experienced trauma or significant hemorrhage. As a result of this study, an increased emphasis of patient warming or rewarming was instituted throughout the Iraqi and Afghanistan theaters of operation. Unfortunately, the same study also shows that 9% of our warriors are dying by sanguination from wounds that could have been controlled by proper hemorrhage control. This training will hopefully change that statistic. When talking about hemorrhage control, it is important to remember our anatomy. Large blood vessels tend to run parallel to our bones, and this is important when we think about the mechanism that we use to control bleeding. Direct compression works because those compressible arteries and veins are being pushed against an immovable object, our bones. The same reasoning explains why tourniquets work so well. When we reduce the amount of bleeding, we reduce the pressure of the flow. This allows the body's natural clotting cascade to work more effectively as platelets begin to form plugs and increase the release of other clotting factors. This is why it's important for any pressure dressing or tourniquet to remain in place, as the release of pressure will often initiate rebleeding, and that results in the washing away of any formed platelet plug, and the body has to start the process from the beginning. So just remember, don't lift those pressure dressings, because if you peak, you'll leak. So what does it look like when a corpsman administers proper care to a patient with an active hemorrhage? The doc will first assess the scene. Why is the patient bleeding? Is it safe to administer care, or would it be best to eliminate a threat? If it's safe to proceed, then our doc will have all the required personal protective equipment in place, so he or she is ready to rock. Usually in cases of major bleeding, it is fairly obvious where the injury lies. If you observe obvious bleeding, apply direct pressure ASAP. Remember that blood vessels run parallel to bones, and when applying pressure to people with a bit of girth, the pressures required to stop the bleeding might be very significant. After direct pressure is applied, check to see that your treatment is effective. Is there still pulsating blood loss? Maybe just a little oozing? Or did you get lucky and completely stop all the blood loss? If you are still experiencing blood loss from the wound, and a little hint here, your patient in this scenario will continue to bleed. If that's the case, just move to a tourniquet. Don't overthink this. Your patient is bleeding, and it's your job to stop it. Direct pressure didn't work, so don't dwell on that as a failure. Just move on to a more effective method, the tourniquet. The rule of thumb for direct pressure and any tourniquet application is the same as what makes for a good haircut, high and tight. Because high and tight is great with hemorrhage control because it's all about location, location, location. You got to get up high. So get that pressure as close to the groin or shoulder as possible, because big blood vessels run next to big bones, and it's a way more effective technique when you compress those vessels as they leave the trunk. Once our corpsman gets the bleeding under control, we would see them assess a patient to determine if the patient is showing signs of hypoperfusion or shock. Another little hint here. Our patient in this scenario will be showing signs of shock, such as an increased heart rate, increased respiratory rate, maybe a decreased level of consciousness, or maybe their skin will be pale or cool and moist to the touch. The brain uses around 20% of the blood pumped with each heartbeat. Since our patient is at least a quart low, it will be difficult to make our heart pump a smaller amount of available blood uphill or against gravity. So we will see our high-speed corpsman lie the patient supine to reduce the chances that our patient's brain is not being adequately perfused. Our doc might even lift the legs to help shunt blood to the organs that lie within the body's trunk. Our corpsman remembers that blood carries oxygen to our cells and will put our shocky patient on high flow oxygen to ensure that every hemoglobin molecule will be fully saturated with oxygen. He or she will also take steps to ensure our trauma patient does not become hypothermic. This can be done by using warm IV bags under the armpits, groin, and head, using a warming blanket, and also by ensuring the environment is warm enough for the patient, not for the provider's level of comfort. More than likely, the patient has experienced profound blood loss, and that will require treatment at a higher level of care. So our corpsman will take this opportunity to evaluate the need for evacuation. So to sum up the treatment, maybe in a kind of a Reader's Digest version, our corpsman will enter the scene with all the proper PPE, will take immediate steps to control bleeding by applying the direct pressure. If that's ineffective, he or she will apply a tourniquet. The patient will then be evaluated for shock, and if shock is present, will be placed either supine or supine with the legs raised. They will have high flow oxygen applied, and the patient will be kept warm. The need for immediate transport will be evaluated and then initiated if necessary. Hey, thanks a lot for your attention. This concludes the video portion of the training. Now we move to test our information retention. Yay! We do this by using our hemorrhage control Jeopardy. So have fun, and we'll see you on the next HMSB.